Good afternoon, everyone. My name's Ian Jacobs. I have the privilege of being President and Vice-Chancellor of UNSW, and welcome to staff, but also welcome to all of our guests today. I'd like to start by acknowledging the traditional owners of this land, their elders past and present. You're all very welcome here today. I particularly like to welcome Minister John Ajaka, who is the Minister for many things in our government, Minister for Ageing, Youth, for Volunteering, for Multiculturalism, all incredibly important things. But on this occasion and on this day, particularly important that he is also Minister for Disability, and he will be speaking to you in a moment before we hear our successful the inaugural lecture from Professor Julian Trollor, who is a neuropsychiatrist and holds the inaugural chair of intellectual disability mental health at UNSW. And Julian has a long history of great success at this university and in Sydney. He qualified in 1989. He achieved his membership of the College of Psychiatrists in 1996. He completed an MD in 2002. He was a junior doctor, I think I'm right. Where's he gone? He hasn't left. Phew, I thought I might have to give the lecture myself. Julian, I think you're a junior doctor on the South East Sydney rota. Intern, RMO, psychiatry registrar, senior registrar and fellow between 1989 and 1996. He became a staff specialist at the Prince of Wales and a conjoint lecturer from 1996 to 2004, a senior research fellow 2005 to 2009. In 2009, a senior medical practitioner at South East Sydney Local Health District and associate chair, and now a chair at UNSW. Many of you will know that Julian's involved in a very diverse range of research programs. And I have to say, we've had a whole series of inaugural lectures this year, but as a medic myself, it's my particular pleasure to be introducing someone who is in such an important area of medicine. Ageing, cognitive decline and intellectual disability in the criminal justice system, human rights and healthcare and intellectual disability, and ageing studies in the general population. An extraordinarily important area of work. And Julian's success, you can measure it in all sorts of ways. Most of all, of course, by the fact that here he is today in his inaugural lecture as a professor at UNSW. But of course, that is built upon over 100 outstanding publications in a whole range of different areas. It's built on the recognition he's received with over £10 million of research awards from NHMRC, ARC, the Department of Health and other areas, on nearly $2 million of consultancies for his research advice, and on other awards in ageing and disability, which I think also total $10 million. So an extraordinarily successful career, but fundamentally the papers and the dollars don't matter in the context of the difference that Julian's work is making to people in Australia and all around the world. And we're going to hear from him talking about improving the mental health and well-being of people with intellectual and developmental disabilities. But before we do, it is an honour to be able to welcome Minister Ajaka to our university. He was a student here for 12 months, so I'm going to take the liberty of calling you an alumnus of this university, and we're very much looking forward to hearing from you today. Thank you.
Thank you very much. Look, I'm thrilled to be here because it is lovely to visit the old university. I made that terrible mistake of transferring to Sydney University to complete a law extension to become a lawyer, but what I'm thrilled about the most is I'm not sitting here doing an exam. I still remember, even though it was the mid-70s, I've never forgotten. Can I firstly acknowledge the traditional custodians of the land and pay my respects to elders past and present. Can I also acknowledge Professor Ian Jacobs, President and Vice-Chancellor, Professor Julian Trollor, the University Chair in Intellectual Disability Mental Health, and it's always great to catch up with you. Every time, this is the one time I'm catching up with you and it's not costing me any funding. That's also a thrill, but I'm sure I'm going to regret saying that when I see you shortly afterwards. It's a great pleasure to come here today to celebrate the International Day of People with Disability. International Day of People with Disability is designated by the United Nations to recognise and acknowledge the achievements, contributions and abilities of people with disability. Today we will mark the inaugural Professional Lecture series hosted by the University of New South Wales by acknowledging the work of Professor Julian Trollor and his team from the Department of Development, Disability and Neuropsychiatry. Professor Trollor has the distinction of being the first university chair in intellectual disability mental health in the world. Through his research and capacity building work, he has systematically built a profile for intellectual disability mental health, both nationally and internationally, over the past 8 years. I'd also like to pay tribute to the University of New South Wales, which through its in-kind support for the chair has significantly contributed to the body of knowledge on intellectual disability. The Chair has been an important New South Wales Government initiative, originally funded under the Stronger Together program and now in partnership with New South Wales Health. The joint funding reflects the collaborative university and cross-agency partnerships that have been developed. The impact of this work cannot be underestimated, with support provided by the university resulting in real benefits to people with intellectual disability, their carers and families. The work by Professor Trollor is building the capacity of both the disability and health sectors in New South Wales at a time of major transition across the sector. The Professor's key achievements include developing core competencies in intellectual disability mental health for mental health staff, free online training modules which provide the health and disability sectors with comprehensive information and training in intellectual disability mental health, extensive cross-agency data linkage work, developing a practical tool to improve the cardiometabolic health of people with intellectual disability, and the analysis of national and state mental health policies which demonstrated that New South Wales is ahead of the other states, and the launch of the first large-scale Autism Cooperative Research Centre to study the health and well-being of adults with autism. On an important day like today, it's wonderful to celebrate the work of the University Chair, who is a champion of transitional research in the issues that impact on people with intellectual disability and with mental health issues. Ladies and gentlemen, it gives me great pleasure to introduce Professor Julian Trollor, and thank you very much for allowing me to share this day with you. Thank you.
Thank you very much, Minister. Professor Jacobs, ladies and gentlemen, it's a great privilege to stand here, and a very humbling one today, as we meet around this important International Day and we shine light on the mental health inequalities experienced by people with intellectual disability. I've had a number of different lines of advice today, including from my daughter who loves dance, that I should do an interpretive dance to communicate my message. I actually think that the academic robes prevent that today, though I very much entertained that idea. And from my son, who quite sensibly said, just don't trip over those things. So here we are today. I think it's important that today is not focused on me, that it's focused on people with intellectual and developmental disabilities. And so through today's presentation, I do hope to achieve that aim of focusing on the people that we're trying to help and focus on the issue that is at hand. Today I will outline, by way of personal reflection, some things that I think have contributed to the development of my work in this area, I'll outline for you the mental health issues experienced by people with intellectual disability. I'll talk a little bit about the strategic approach we've taken as a department in developing a strategy to attack this issue. I'll also cover incremental progress in the area as we look at building a better future. And I'll look at priorities for the future and how we can move from just incremental progress to more substantial reform in this area. So first, perhaps, to personal reflection. Well, I think, if I can learn how to drive. Yeah, I think they say attitudes are formulated very early in life. And perhaps this picture says it all. So this picture is a picture of me in my early life. And I don't think the tongue has stopped moving since that time. And I think the hands on the hip posture suggests an academic career. But perhaps a lot of hard work has been done since to realise that. Secondly, mentorship. I'm particularly thrilled that Dr. Helen Maloney is in the audience today. Helen was instrumental in getting me into this area clinically. Her incisive clinical approach with people with intellectual disability, often people with most severe disabilities, was incredibly instructive, as Helen taught me as a registrar to evaluate the influence of environmental factors on the behaviour of people with intellectual disability and on their mental ill health. So I thank Helen for that great role in mentorship, as it was quite instrumental in getting me into the area. I also would like to acknowledge the academic leadership and excellence and the mentoring in the way of seeing strategies and initiatives develop by two very senior academics at UNSW. These two, they rarely stand still long enough to be photographed together. But Scientia Professor Henry Brodati and Paminda Sachdev have really been instrumental as my thesis supervisors in modelling that academic leadership. And I really do hope I can do that justice. And lastly, by way of personal reflection, inspiration, which comes for me from my family, firstly my extended family, and more recently from my family, my wife and my children, who allow me to indulge in this area, from my deep-centred Christian faith, which helps me as I think about how to help others, and most importantly, the inspiration I gain from people with intellectual and developmental disabilities who inspire me every day in my clinical work and as I work with people with disabilities in advocacy and as I experience the joy of being able to lecture and teach with people with intellectual and developmental disabilities here at the university and in other settings. So these are truly inspirational people who overcome many barriers to do those things. So, mental health in people with intellectual disability, what is the big deal? Well, we know from studies of the general population that the general population experience mental ill health at a rate of about 2 in every 10 people per calendar year. That statistic is quite alarming, but when you compare it to the rate of mental ill health in people with intellectual disability over the same period, you see quite a significant elevated risk for mental ill health. And then if you look at those around the person with intellectual disability, carers, we see rates of mental ill health substantially above the national average. There are many risk factors for mental ill health in people with intellectual disability. There are shared risk factors for both mental ill health and intellectual disability, but also there are things that are experienced by people with intellectual disability, including biological risk factors to do with the development of the brain and to do with some of the genetic determinants of disability, to do with the psychological aspects of being able to deal with psychologically what is happening to you from a day-to-day basis and provide a response to that, to do with your past experiences, bearing in mind that people with intellectual disability have much higher rates of abuse experiences in their background than the general population, to do with lifestyle factors such as reduced ability to partake in various day-to-day activities, and lifestyle factors such as exercise, which are preventative against mental ill health. Also environmental factors. Many people with intellectual disability have reduced choice and control, so that you may not get the opportunity to choose where you live, or who you live with, or who supports you in your care. And this can provide stress. As well, there are many social determinants of mental ill health that result in a higher burden of mental ill health in people with intellectual and developmental disabilities. When you think of this additive risk and you place it in the context of reduced access to quality healthcare, you can see that we have a problem. So there are a number of barriers to people with intellectual disability accessing healthcare. Some of those are to do with the person themselves. So if I'm a person with an intellectual disability, I may struggle to communicate my needs and my emotional responses to other people. But also there's a system issue in that many of our systems of support, including mental health support, are not well interlocked and not working together in a seamless way to allow access to, treatment in, and then movement out of the system effectively. In addition, because of historical factors that have led to the separation of disability and health services, we now have a health service system full of practitioners who are very good at what they do, but who know very little about disability and health. And I think we have a major job to do to improve that. So, onto a strategic approach. The approach we've taken in the department has been to develop a focus on this area. From the original funding given by the New South Wales State Government, we now have approximately 20 staff, a mix of full and part-time people who are dedicated to working in this area, and I thank them for their daily enthusiasm and reminding me of why we're there. This has been a privilege to lead this team. We've been informed by our strategic plan, and thanks to the renewal of funding from both the Ministry of Health and the Disability Services, we now have a need to develop our strategic plan for 2016 and beyond very rapidly. Fortunately, we've preempted that and we're working on it now. But this plan is informed by a very clear vision of the highest attainable standard of mental health and wellbeing for people with intellectual and developmental disabilities, a clear mission statement, and has as its guiding principles at the highest level a human rights framework. I do think that is very important in this work. Our main work, it fits neatly into three different sectors: into the research, into consultancy, part of which is clinical work, and into building capacity in the service systems. It's especially exciting today to be able to launch a new logo for our department. And I thank Heather McCarthy, an artist with an intellectual disability, for providing the inspiration and the artwork for our logo. Heather is a woman with an intellectual disability who lives in Sydney with her family, and I understand her mother, Robin, is in the audience today. Heather attends Maroma, which is an Inala day service where she enjoys performing, doing her artwork, and this is the artwork that inspired our logo. And this is how we've incorporated it into a new logo that has been integrated with the university logo. And you'll see that appearing on the bottom of each of the slides today. It's especially important that it reminds us of why we're here doing our work, and it inspires us to develop translational tools that are of benefit to people with intellectual and developmental disabilities. I also want to acknowledge the core funding that comes from the department, the Ageing, Disability and Home Care, part of Family and Community Services in New South Wales Government, and from the Mental Health and Drug and Alcohol Office of the New South Wales Ministry of Health. And it's a special delight on a day like today to feel secure that at least in the medium term we're going to be able to sustain effort through the funding that has been given by both those sectors of government. But of course there are many other sources of funding for projects and research that has to be hard won and it's a continuing effort to attract those resources. A large part of our ongoing work relates to funding from an NH and MRC Partnerships for Better Health project, which I lead, called Improving the Mental Health Outcomes for People with an Intellectual Disability. We have a great array of chief investigators as part of that project, associate investigators who are excellent, and 12 partner organisations in government and other agencies who help us make sure that what we do is real and bringing tangible benefit to people with intellectual and developmental disabilities. So what incremental progress has there been? Firstly, I highlight some work by the New South Wales Council for Intellectual Disability by way of hosting a national roundtable in Canberra in 2013. That was jointly hosted by ourselves, the Australian Association of Developmental Disability Medicine, in which I'm heavily involved, and the Queensland Centre for Intellectual and Developmental Disability at the University of Queensland. There we identified key elements of reform that needed to occur in order to improve the situation of access to skilled treatment for mental health conditions, and I've listed them there. Last year, we helped the New South Wales Council for Intellectual Disability audit incremental action that had occurred in the year following that national roundtable, and I base some elements of my discussion today on some of those moves forward. Firstly, inclusion in mental health, in all mental health initiatives. If we're to make a difference, we need to make sure that a minority group who is at substantial mental health disadvantage are actually included in all mental health initiatives. Well, what's happened since? Our work with the NHMRC Partnership Grant, led by Associate Professor Leanne Dowse from this university, really helps us understand that. So Angela Dew and Leanne Dowse conducted a policy analysis with us on the state of mental health policy in various states in Australia and nationally, and looked at the degree to which intellectual disability was represented in that policy. Mental health policy strengths generally that stood out that help us and equip us for including people with intellectual disability include things like values-based approaches, recognition of diversity, life course approach, focus on workforce development, and building in checks and balances. Mental health policy weaknesses, however, are largely around any substantive content related to people with intellectual disability in them. So we see a lack of inclusion of this group repeatedly, a lack of articulation of how you go from theory to practice in the policy. And so what we need to do now is to lead developments both at a state level and nationally in policy, in inclusive policy development. For example, by developing toolkits for governments and agencies for better inclusion of people with intellectual and developmental disabilities, and to aim for a very coordinated national approach to this issue. It's been pleasing to see that some state-based initiatives, including that by the New South Wales Mental Health Commission in its report and in its strategic plan, include people with intellectual disability at the centre. And this is one such example in the Living Well report. And then in the New South Wales Mental Health Commission strategic plan, there was a clear section on people with intellectual disabilities and 5 very concrete points with sub-points under them for actions and priority. So far in the New South Wales government response, there has been significant overhaul of the mental health service system, but people with intellectual disability haven't been named as a special area of interest and capacity development. I hope as the government response to the plan continues to grow and mature, that will be something that will occur. What about at a national level? It was very pleasing to see a year ago in the report of the National Review of Mental Health Programs and Services by the National Mental Health Commission that there was significant mention of intellectual disability and recognition of this group as one of substantial need. Several possible avenues of capacity development were seen. Just recently, the Australian government's response in terms of this report, Contributing Lives, Thriving Communities, has no specific mention of intellectual disability. It has some but limited scope to include people with intellectual disability in some of the initiatives. But it's disappointing that we have this discordance between what the sector and review thinks is needed and what actually has been taking place. So, what about equitable access and skilled treatment? How do we make a difference there? We were fortunate to receive funding from the Commonwealth Government to develop a national guide, Accessible Mental Health Services for People with an Intellectual Disability. This is one of a 3-part funding requests we made to develop a guide and to develop a toolkit for professionals and for services, and a toolkit for consumers and carers to enable them to understand what to expect from services in this area. And again, this guide is adorned with artwork by people with intellectual disability that makes it a very appealing and engaging document. It contains guiding principles, which of course are around rights, inclusion, person-centred approaches, promoting independence, practising in a recovery-oriented framework, and with good evidence base. It identifies key components of accessible mental health services and goes into a lot of detail about them. It outlines implications for all mental health services as we seek to equip our services for people with intellectual and developmental disabilities. And it has very clear implications for core service components for primary care, where the bulk of mental health care occurs, in the public mental health service, in the private mental health service, and in specialised health services related to people with intellectual disability. It acknowledges that the job is tough, so that if you wanted to be doing a bare minimum, we've got fundamentals in there. And if you want to be doing a better job, we've got recommendations for further enhancements of practice and a range of tools for inclusive practice that you see here. This document was developed after extensive national consultation and input from a really large sector indeed. We don't, however, have ongoing funding to develop the toolkits that I mentioned. So we have a great document, but a lack of vision in terms of implementing that document, not a lack of will from us, but a lack of funding for the implementation of this work. What about workforce and education and training? Have we made some progress in terms of incremental action? Well, a lot of our work revolves around education and training initiatives. The bulk of our work is on the left-hand side of this panel, with thinking about the future doctors and nurses, thinking about the current mental health workforce and the disability workforce. What largely is missing in our work and what needs to be done is work with families, with people with disabilities, and the broader service sector to actually include them. We conducted an audit of medical and nursing curricula nationally to determine what the extent of intellectual disability health content was. What did we find? Well, when we examined medical schools across the country, we found that there was a mean of only about 4 hours of compulsory content in those medical schools that responded. Only 2 medical schools offered content that included both physical health and mental health related to people with intellectual disability. And there was very, very poor representation of core elements that are of importance to this group: human rights and healthcare, sexual health, emergency medicine, interdisciplinary ways of working and preventative health. And only 5 medical schools offered direct contact with people with intellectual disability. When we looked at nursing schools, less than 50% offered intellectual disability content of any sort, and the mean number of hours was 3.6 hours across the whole curriculum. Less than a third of schools covered both mental and physical ill health, and human rights in healthcare and preventative healthcare were really poorly represented. Only 1 school offered content involving a person with intellectual disability in its development or its delivery. So you can see that our medical schools and our future nurses and doctors are not being equipped to practice in this area. What we need to do is to look at whether we can install minimum mandated content and develop curriculum toolkits to make it easy for nursing and medical schools to embed content within their framework. This is hard because there's such competition for space in these curriculum. What about the mental health workforce? Well, we began with a workforce survey trying to understand the current skills and attitudes and training needs of the mental health workforce in New South Wales. We developed workshops which we ran successfully, and then we transferred that learning into an e-learning package. So far, this e-learning package has been incredibly helpful for people. We have over 6,000 registered users who can work in a self-paced way and engage as deeply as they wish with the material to really improve their learning. And we're constantly releasing new modules in this e-learning. We've also developed a competency framework. This competency framework aims to build workforce capacity essentially by defining and promoting the attributes required of mental health professionals as they work with people with intellectual and developmental disabilities. The text has been finalised, the formatting is coming along, and again we've embraced the artwork of people with disabilities in these documents as we develop comprehensive toolkits for clinicians to be practical. It's one thing having a competency framework asking people to do something, and it's another thing to actually be developing a practical tool that people can use in their daily work. Obviously, we'll be launching that hopefully with great acclaim. It's the only such competency framework in existence worldwide. There is nothing else like this internationally. So it's quite innovative in a way, and we do hope that it will have an impact on our New South Wales mental health workforce. Projects like this are only possible because people give up their time in steering committees and groups, and projects like this are funded, in this case funded by the Ministry of Health through the Mental Health, Drug and Alcohol Office and Children and Younger Persons Unit. We're moving on to develop modules for the disability workforce, and we'll be releasing them 10 modules for the disability workforce through next year to equip people who work with people with disability to recognise signs of mental ill health in people with disabilities. This is of tremendous importance as we try and improve access to services and supports. It's important we also allow the service to equip itself with knowledge about how to interact with health services. A lot of the time we're not speaking the same language. We think we are, but we're not. Or we're not providing the information that might help the mental health clinician. And the mental health clinician isn't necessarily supporting the implementation of their recommendations in the way they talk to and instruct the disability worker. But we do need to move on to develop further tools, and I'm hopeful that the next 5 years of work that we undertake will be much more inclusive of families and people with disabilities and the broader service sector in terms of the education and training initiatives. What about addressing multiple disadvantage? Well, if I could highlight something, at first pass it may seem like responsible prescribing and cardiometabolic health don't go together, but for this group they do. People with intellectual disability have higher rates of prescribing, particularly of psychotropic medications, which often start early in life. It probably would surprise you to know that the biggest class of medications prescribed to people with intellectual disability are actually psychotropic medications. So they lead the way. And when you look at stratifying those medications by the type and the purpose, you see that people with intellectual disability often miss out on medicines that are used in preventative health, our cholesterol-lowering drugs, our blood pressure medications, our anti-diabetes medications. But at the top we have these medications that often compound cardiometabolic risk. So the two do go together. We've interrogated a number of data sources, including a national general practice data source, which confirms this problem in Australia and confirms the really different style of practice, which is dominated by paperwork, attending to mental health and behavioural needs, but actually not getting to preventative health aspects. We've developed guidelines for prescribing that we've published. We've developed e-learning resources around this issue and contributed to policy development. More recently, though, what we've done is develop with leaders in the field, both nationally and internationally, a positive cardiometabolic health framework for people with intellectual and developmental disabilities. This piggybacks on movements in the mental health sector generally to have a real focus on improving health outcomes for people with mental ill health. And so it's very timely that we've been able to harness this momentum toward people with intellectual disability. We've developed, with funding again from New South Wales Health, a suite of resources that will be launched through next year, which really help in responsible prescribing in people with intellectual disability and in how to mitigate risk of cardiometabolic problems. And so there'll be a suite of online and resources which people can click on. They can print off resources for patients and families, and they can improve their practice and hopefully improve the health of people with intellectual disabilities. Another group of particular focus in our work has been people as they age with disabilities. Often, as people with disabilities age, they age prematurely. So by the time you're in your 30s and 40s, you're likely to have a number of chronic health conditions that need to be managed. As well, you're beginning to develop the consequences of premature ageing, and often if you're in the context of being supported in a family home, the needs of your family carer as they age are then colliding with your own. And so we have a real problem here. We also have the problem of an overrepresentation of dementia, the prevalence of which is about 3 times that of the general population in people with intellectual disability. So this has been a source of significant focus, and we hope that we'll develop translational tools as we've documented the health profile, the mental health profile, the service use and participation, and care, health and wellbeing for this group. And again, we're hoping we've received some funding. Dr. Liz Evans has, from my department, has received an NHMRC Dementia Fellowship recently, and this will help equip her, allow her to focus on development of translational resources in this space. I'm also delighted that today's talk links somewhat with a release by Alzheimer's Australia today, Alzheimer's Australia New South Wales, of a resource specifically for living with intellectual disability and dementia. And we've contributed to that resource. It's been released today, and I do hope it's of value to the sector. And finally, I'd like to touch on data collection and interrogation. As the Minister said, we've been involved in using big data in health and disability services to really interrogate the health and wellbeing of people with intellectual disability. This is a huge undertaking and one in which we've really learned as we go. So far, we've linked the Disability Services minimum data set to the admitted patient data across the state, to the emergency department, and to mortality data. Now, these are administrative data sets collected for administrative purposes. They can be linked in a de-identified manner that allow researchers like us to then ask questions of the data related to the health status of people with disabilities and outcomes for people with disabilities. So let me illustrate some of that. Our data linkage interrogation so far has focused on mental health services, on emergency departments, and on mortality, and we're moving on now to non-mental health admissions. Here's a snapshot of the story around mental health admissions for people with intellectual disability. In New South Wales, in our study period from January 2005 to June 2012, there were about 110,000 admissions for a mental health problem in New South Wales, and thousands of those were related to people with intellectual disability. Now, compared to people without intellectual disability, people with intellectual disability were more than twice as likely to be admitted. They stayed twice as long. They therefore cost twice as much. They're more likely to be younger, socially disadvantaged. They're more likely to be admitted to hospital via law enforcement agencies. They're more likely to have schizophrenia and less likely to have common disorders like depression and bipolar disorder. And we think that relates to a filter effect, that if it's only that you get through the door if you're very, very, very unwell. And we think that filter effect then affects the diagnostic profiling we see. And people with intellectual disability were 5 times more likely to be given no diagnosis. That is, we probably don't know what's going on. And I think that speaks to the complexity of this group, the difficulty identifying clear mental health symptoms in some individuals, and then the difficulty clinicians have working in this space when they're ill-equipped. What about the emergency department? Well, we looked at data from about 50,000 people with intellectual disability presenting to emergency departments between 2005-06 and 11-12. Nearly half of these people had at least one ED visit. ED visits were twice as likely for a person with intellectual disability compared to the general population. And there's a spike in the very young and in midlife, so it's quite a different profile to the general population. People with intellectual disability are far less likely to come to emergency with GP-type presentations, so where you could have otherwise gone to see your GP electively for the problem. People with intellectual disability were twice as likely to come via ambulance, 4.5 times as likely to come via the police. Their average wait time, surprisingly, was longer. The cost per person was twice as high because they're presenting twice as often, but the ED visit cost is no different. Now, importantly, in this data set and in our other data sets relating to admissions and ambulatory mental health services, we see that people with intellectual disability who are not receiving disability supports are much more likely to cost the system more, to stay longer in the system, and to be a complicated assessment and take longer during the consultation. We see that repeatedly in our data sets, suggesting that a disconnection between disability supports and health supports really make life very complex indeed for an individual. I think that's a message as we move into a new era of disability service provision with the National Disability Insurance Scheme, and making sure people's disability supports are also taking into account the health-related needs and allowing the person to interface with the health system in a really helpful way that ensures a really positive experience in the health system. And finally, I move onto a very sobering topic, mortality in people with intellectual disability. I think it's here where we see a really stark reminder of the health inequalities experienced by people with intellectual disability. In a very large sample of people studied over 7 years, we compared mortality to the New South Wales population. We saw that across all age ranges, the age standardised mortality rates for people with intellectual disability were really substantially higher than the general population. I can show you that by drawing your attention to this bottom line here, the comparative mortality figure. Taking into account differences in the two populations related to age and age distribution and gender, people with intellectual disability had a death rate 2.6 times that of the general population. So how stark is that? When we looked at classifying the deaths as potentially avoidable, that is, where there was a condition which could have received treatment that could have prevented death, we saw that over 1/3 of deaths in people with intellectual disability were from a potentially avoidable cause. That rate is double that experienced by the general population, double that. When we looked at the cause of death coding in people with intellectual disability, we saw something really quite peculiar, that death coding often was coded up to the intellectual disability itself. So if I was a person with Down syndrome and I died no matter the cause, the coding was labelled Down syndrome. If I was a person with cerebral palsy, it was labelled cerebral palsy. So you can see we have a problem. Unless we know a cause of death, we can't take action to prevent death. Now, painstakingly, myself and others recoded all the deaths data to the next in the series up from where it was labelled Down syndrome or cerebral palsy. And so we were able to get a more comprehensive picture of the profile, which was dominated by respiratory deaths, deaths from infection, deaths from cancer, cardiovascular disease, and neurological causes as the top 5. Now, when we look just simply at the median age of death in New South Wales, for males with intellectual disability, it was 48. For females, 45. There's a bigger gap here for females. Normally we see in population statistics that females live longer. Not so here. When we compare that with the general population, there's a big gap. Males 79, females 84. These are statistics from the time of the study. so we now live a little bit longer. When we compare that with Indigenous statistics, the same statistics, the median age at death at that time point when we were collecting this data, Aboriginal male 60, Aboriginal female 64. We have a wonderful and comprehensive close the gap strategy for Indigenous Australians, which is fantastic. We need a very similar thing for this group, bearing in mind that the mortality statistics tell us that the health inequalities are really quite substantial indeed. So this big data work is very valuable. It has its limitations, it has its critics. I'm aware of the limitations. It can tell us something about people with disability who access disability service systems. We're extending our data linkage to look at the justice system, to look at people with intellectual disability who have contact with the criminal justice system, to look at people within the education system and their mental health needs, and to link to other important data sets such as those held by the New South Wales Public Guardian and the New South Wales Ombudsman, who really, through extensive reports, has highlighted disability deaths within disability accommodation. So in summary, people with an intellectual disability have very high rates of both multiple disadvantage, physical and mental ill health. And there's a significant health gap. There are multiple barriers to access to timely and effective mental health care, but there's some incremental progress that's occurred. Key priorities have been identified and action has been taken, but it's pretty slow. And there are some clinicians, some researchers working in this field who've built an incredible knowledge base in this area well before I became involved. And I acknowledge their efforts. So it's not to minimise those efforts, but I think there are a number of things conspiring against us to make progress slower than it really should be for such a population of need. So what can we do? Well, we have a changing environment with provision of disability services in an insurance model through the National Disability Insurance Scheme, and that gives great choice and control to people with intellectual and developmental disabilities. So we need to remember that whatever we do has to be relevant to that changing landscape. We need, therefore, very strong partnerships between disability services and health services, and we need to link those services together. Maybe primary health networks are a key linchpin there. We need continued health advocacy. Health advocacy gets us somewhere. Often people with intellectual disability and their carers struggle to have a voice. This is an area in which resources are thinly spread. People struggle with time demands. When we approach people to participate in studies, they often give their time in a very generous way, but they're very time poor and stretched. But health advocacy, if we can mobilise that in a cohesive way, really helps. So I'd encourage you to get involved. And we need to build on mainstream reforms, be opportunistic where we see an opportunity within a mainstream reform, get in quick and advocate that people with intellectual disability should be included. There's much more work to be done in equipping the current and future health and disability workforce. We need to equip mainstream services. There are no public mental health services at the moment that have easy English summaries of mental health documents that are normally presented if you're admitted to a mental health facility. We need to change that and provide information, and at every step of the way, whether it's health, physical health or mental health, we need to be looking at making reasonable adjustments to make sure that people with intellectual disability are able to access health services in a much more meaningful way. We need to connect services and map service pathways so that people can move seamlessly through the health system and back into the disability support service. And that takes integration of service models and a willingness across the boundary of health and disability services to do something. And we need to further develop the capacity of services for people with more complex and specialised needs. But these are really incremental steps, and I think one thing I've learned from the last few years is that I'm incredibly impatient. And what I think we need to do is have a shake-up, not just be satisfied with incremental progress, but insist that really we need universal identification of the needs of people with intellectual disability in all health and policy developments, in all health and policy planning reforms. We need accountability. We need reporting of health outcomes for this group. We need reporting of deaths for this group routinely by government, and we need to see incremental progress on those issues. I think the linkages between the NDIS and personally controlled electronic health records and Commonwealth systems may enable that in the future. And I do think we need a national strategy similar to Close the Gap for this group. I'm absolutely thrilled that you could come today, and I'm in awe of your commitment to this area, your interest in this area, and I'm very humbled by that. This day is about people with disabilities, not about me. Thank you for coming.
From time to time, when societies become affluent, they, or at least a subset of those individuals in that society, pause and think. Perhaps my favourite depressive character of history is Dr. Samuel Johnson, who was the first great lexicographer and who spent most of his life in London near Fleet Street. And his reflection on the stabilisation of society at that period in London in his life was that we should not be concerned with the diets of kings, but we should be concerned with the lot of the poor. That sort of grand tradition of trying to understand what a just society, what a good society should do, was then reflected by other thinkers in a more liberal age beyond Johnson, and it was again a reflection that what is a successful society? A successful society is one that looks after all its members in the best possible way. Now, that responsibility of those thinkers, and of course we know what intellectuals are like in society, they're very good at coming up with problems. They almost invariably can identify a sort of general way of thinking about things, and indeed Professor Jacobs employs people who do this sort of thing in this university. But what about the realities in society? So our record as doctors, for example, in medicine is not desperately good in the area of mental health. And until very recently, the stigma that pertained to mental health was also carried to some extent, I have to say, by the medical profession itself. After all, the ghastly treatments that were played on people in the 20th century were not exactly admirable. Prefrontal leucotomy, for example. Now, there have been glimmers of hope. In fact, Elks, the individual who first tested chlorpromazine on British patients in Birmingham, has just died at the age of 103. So we're still in an era of quite early stages in improving what we do. But I think we have to reflect quite carefully on what we do next. The other day, I ran into a Sydney lawyer, happens to be a very good friend of mine of 40 years standing, and he was a bit put out because his share portfolio had slumped somewhat, and he was no longer able to consider replacing his Robinson R-44 helicopter with a larger version. The other day, I parked my car in the wrong place in a suburb called Wallara, and I was fined $250. I'm paying over 52% of my income, thank you very much, Vice-Chancellor, in tax. We have a very affluent society. We are in a privileged position. And I think we now should be, and I'm sure we are, visiting the questions that arose to those great English liberal thinkers, but with all the more necessity given the way our society is. So I suggest this to you, that the advocacy for those who are disadvantaged, who are disabled, who are poor, is something that we must continue. The record in the 20th century is not perfect. There have been reversions to very poor and appalling reactions to this problem. I only need to mention eugenics and the interwar period in Germany. Therefore, I would say this to you, as a society as a whole, that we owe it to our current generations and our future generations that we look across society and do the best for all. I exhort you to remember those words. Thank you very much.
We heard a wonderful inaugural lecture this evening, followed by a powerful exhortation from our Dean of Medicine. It's been a very memorable occasion, and it's great to have had the Minister here as well to be part of this. I'd like to invite Julian to come up the front again, and to give you the opportunity to give him another round of applause for a truly memorable inaugural lecture.